Right, so I hope everybody can hear me. Can you just raise your hands, please? Welcome, everybody. So good morning and welcome to our live Global Breast Cancer Tumor Board, to all participants and viewers from around the world, and a special thanks to the doctors who will present our cases this morning. Dr. Marina Costa from Barretos in Brazil, Dr. Conceição Campos from Fortaleza in Brazil, and Dr. Yuli Remolina from Mexico City in Mexico. And a special welcome and thanks to our panelists from MGH and around the US. I'd like to please emphasize our usual housekeeping rules for first-time attendees. Please keep your microphone on mute unless you are speaking. It helps everybody to hear the tumor board. And as a reminder, all PowerPoint cases presented this morning and the YouTube live recording that's taken are archived and categorized online for your and other people's review after the tumor board is complete. So if anybody wants to review a tumor board afterwards, they're welcome to do so. Jessica will try to circulate references and articles and studies, any information of interest. Jessica will try to circulate it to all attendees afterwards. So you don't need to write down. If Alphonse mentions an interesting study going on, we'll send it to you afterwards on a more formal link, so you'll have access to that. So with that, thank you very much, and I think we can get started. And the first case this morning is presented by Marina Costa. And Marina, we'll just put the slides on, if you don't mind, and unmute your microphone, Marina. And
okay,
then when the case is ready, you can stop. Just give it a second.
Okay.
There's our panelists that we expect this morning, and our three presenters, and we can go ahead, Marina. You can start presenting your case now. Thank you.
Okay, thank you. Good morning, everyone. At first, I'd like to thank you all for this opportunity. My name is Marina Costa, and I'm a member of oncology team from the Barretos Cancer Hospital. This case is about a 31-year-old woman with no previous disease, no family history of cancer. In her gynecological history, she had 3 pregnancies. Her menarche was at the age of 13 years old, and her last menstruation period was in April 2014. In her clinical data, she noted a rapidly growing mass for 2 months, and her ECOG-PS was 0. Next, please. Her breast MRI showed a suspicious heterogeneous nodule with irregular margins, measuring 8.9 by 5.6 by 4.6 centimeters in medial quadrant, several confluent satellite nodules in superior medial quadrant, the largest measuring 2.3 by 2.0 by 1.3 centimeters. The right breast shows simple cysts, positive lymph nodes on the left side. Her core biopsy showed ductal invasive carcinoma, grade 2, with ER 8% positive, PR 10% positive, HER2 negative, and Ki67 40%. Her staging workup was negative with PET-CT in April 2014. So at this moment, she has breast cancer stage CT4, CN2 at this moment. She underwent neoadjuvant chemotherapy with paclitaxel for 7 weeks, and she had local progression. So she underwent dose-dense AC until August 2014. In September 2014, she underwent left mastectomy plus axillary lymph node dissection. The pathology report showed residual invasive carcinoma grade 2, 5.3 centimeters, and DCIS grade 3. 21 axillary lymph nodes out of 39 were positive, with tumor-free surgical margins. So she has IPT3, IPN3, residual cancer burden was 3. She was referred for genetic counseling, but she didn't participate because she lives far from Barretos. She received radiation therapy until December 2014 and tamoxifen from October 2014 until August 2015. The public health care in Brazil doesn't pay exemestane plus glycerin, so it was discussed with patient and she decided to proceed to bilateral oophorectomy on May 2015. In August 2015, she returned to hospital feeling headache and vomits since July 2015. The CNS MRI showed a expansive metastatic lesion with vasogenic edema located at cerebellar vermis, core capsular left region, left temporal lobe, and right frontal lobe, with compression of the ventricle with midline deflex to the right. This is the MRI showing the lesions and the edema. So in 2015, her staging workup, again with CTs and bone scans, were negative for metastasis. Her ECOG-PS was 2 at this moment. She underwent whole brain radiotherapy until August 2015. And the question and discussions about this case are, what would be the best approach for this patient? Chemotherapy for metastatic disease? What is the choice of therapy? Endocrine therapy only? Best choice. Continue tamoxifen. Change for aromatase inhibitors. Is this a role of radiosurgery after whole brain radiation? She will have a CNS MRI next month. Thank you.
Thank you, Riz. Thank you very much. And just put us on speaker. Yeah. Can I start by actually changing the question slightly and ask, welcome and ask Ben Park. Ben, do you have any comments about the use of neoadjuvant therapy in this high-risk, young 31-year-old ER/PR positive tumor, and your comment about the choice of treatment and the indication for treatment, and do you agree with this approach?
Well, I think you raise a good question in that, we know that the best response rates are seen in the triple-negative population for neoadjuvant therapy as well as the HER2-positive, which she has neither. And so I'm not sure that would have been my first kind of approach to a patient like this, particularly, in hindsight, we can all say, oh, it looked like she might have grown through the first 7 cycles of Taxol. But it is somewhat worrisome that in patients that who are not going to get a high likelihood of pathologic complete response, whether or not this is worth it, particularly in a young patient. That said, if she really wanted a shot at lumpectomy or breast conserving surgery versus mastectomy, that's a reason and an indication of itself. And most patients will have some response. So I think this was a little bit unusual that she looked like she progressed. But certainly her disease seemed like, based upon this neoadjuvant regimen, that her disease was chemo-resistant from the get-go.
Thank you. Rasheen, do you want to add something?
Yes, I would actually maybe disagree a little bit with Ben, even though he's just across the corridor from me. I would say that this patient is somebody who I would have recommended a third-generation regimen to, no matter what her receptor status, because she had, a very large tumor mass. She had node-positive disease. So I think that even if she had had surgery first, I would have recommended adjuvant AC followed by T, or the other way around, whatever the institutional preference is. So in general, for patients with node-positive disease who are grade 2 or 3, if she was grade 1, I think it would be different, but a grade 2 tumor with a Ki67 of 40%, with the known caveats about Ki67 staining, I would actually have been in favor of the approach that was recommended.
Can I just interrupt for a second and remind everybody that Dr. Cynthia Villarreal in Mexico City is undertaking a research study of genetic testing for South American patients generally with an investigator at the City of Hope in the United States. So anybody who has a young patient that you wish to be tested, but you find it logistically difficult to do it locally, please feel free to contact Cynthia, and we will distribute the details of this research study for genetic testing. They are looking for founding mutations in the South American population. So we will circulate that to facilitate genetic testing. So can we go to your next question? Let's have a look. Your next question was the choice. Now, at this point, and again, I call on the medical oncologist perhaps, at this point, when she's discovered to have this very dangerous CNS metastases, but no other systemic disease apparent. I think I'm right in saying that. Would you couple treatment of a CNS lesions with it automatically giving additional therapy for putative stage 4 metastatic disease in other organs or not? That's quite a good question, actually. So again, I call on Ben or Rasheen, one of you or both of you, to answer, please.
I'll just go first since I just unmuted. I actually think that in the absence of any other disease outside the CNS, I don't see what the role would be for maintenance chemotherapy per se, because we don't really know what we're treating, and in a metastatic situation, I'm not sure what your endpoint would be. So I would be perfectly okay with some sort of endocrine therapy, and I know that's going to be a later question, but I don't actually see much value in giving chemotherapy at this point in the absence of any obvious visceral metastasis. And I will say, I do agree with Rasheen. I guess I should qualify that maybe my approach would have been, having had progressive disease after 7 cycles of Taxol, that might have been a point where I think talking with surgery and then giving adjuvant therapy afterwards. I certainly would not deny a patient standard of care neoadjuvant adjuvant therapy. Again, I'd be a little bit worried with progressive disease after 7 cycles of taxane not to do surgery at that point.
Thanks, Ben. And now we get to the radiation question, and I'd like Alphonse Tagian to comment on that, please.
Yeah, I think it's good and bad. The good thing is that that's the only site of disease, but the bad thing is that each of these metastases is rather large. The question is, can we do stereotactic radiosurgery? Yeah, I certainly hope we can add a boost to these 3 metastases with stereotactic radiosurgery. Although the success of stereotactic radiosurgery relates to the tumor size, the smallest, the better. But at this point, I think with whole brain radiation, I would guess probably 30 gray in 10 fraction. I think the recurrence will be quite high because.
So sorry, for those of us less familiar with this, Alphonse, yeah. Is the first treatment whole brain radiation followed by radiosurgery, or is it what sequence?
I think nowadays we usually give stereotactic radiation. A patient like that would have had a consultation with a neurosurgeon, sometimes even with multiple brain metastases. They can remove one, for instance, the one which is at the periphery here, if it is safe. But so assume the neurosurgeon say, no, I cannot operate. We would have given just stereotactic radiosurgery. We really keep the whole brain radiation for a recurrence. And the reason for that, there is a lot of data suggesting that whole brain radiation can really influence or impact the cognitive cognition of the patient.
Subsequently, yeah.
Yeah. So that's what is being done, but it doesn't mean that whole brain radiation is wrong. But so this will be what used to be done a few years ago, just give whole brain radiation and then top it with a boost of stereotactic radiosurgery. So you give stereotactic radiosurgery, you will maintain a sort of local control of these 3 lesions for a period of time. And that's what we recommend.
So can I just re-emphasize what Alphonse just said? The 2015 approach at MGH would be, number 1, a neurosurgical opinion about excising perhaps the largest peripheral lesion of the CNS. Number 2, to go directly to stereotactic radiosurgery as opposed to whole brain radiation because of complications of late cognition associated with whole brain radiation. And so that's a slight variation on what was done, although Alphonse has said already, just reverse the calendar by 1 or 2 years, and this is exactly how the patient would have been treated in Boston, how you've done it here, the sequence of events. So I don't know whether Seema Khan, from a surgical point of view, do you have anything to add to this case right now, this young woman with a high-risk ER-positive disease treated with neoadjuvant therapy, 21 lymph nodes left behind afterwards? Do you want to say something about, just before you answer, Seema, something about local radiation, now that she's got brain mets or after the surgery?
Well, I think she received her local radiation before the brain mets.
Okay.
So that's the right thing to do. I would guess she received chest wall, supraclavicular, and auxiliary radiation plus IMC radiation is almost the standard of treatment. And it seems to me that she has so far a local control of her chest wall.
Right. Seema, do you have any insights for us? No, we can't hear you. Can you turn your microphone on, please?
Is it on now?
Yes, thank you. We can hear you now.
So I think just a couple of minor points about the initial presentation and workup would be that there wasn't any mention about any investigations other than MRI. And for someone with a palpable mass, typically the imaging would start with a mammogram and ultrasound. MRI is, of course, often helpful in delineating the extent of disease, but these other simpler tests are very useful as well. I wasn't sure why this was classified as a T4BC because there wasn't any information presented about it invading either skin or chest wall. In terms of the staging of the tumor, it would seem to be, from the description, to be more of a T3 lesion. That doesn't necessarily these days have any implications for use of neoadjuvant chemotherapy, as has been discussed. But given the extent of disease through the breast, it seems unlikely in an ER-positive tumor that she would have converted to breast conservation.
Well, actually, can I be the devil's advocate and say that she had a breast MRI and then she had a PET scan instead of like multiple local scans? Do you believe that PET scan is better than CAT scan and bone scans and things from a cost point of view? Is this your choice of approach to use PET scanning? Yeah.
We don't. So at Northwestern, we don't use PET scanning except for problem solving. The initial approach is CTs and bone scan, radionuclide bone scan.
Yeah. The same approach here is at Mass General. PET scan is really rarely done in these situations.
I think this is an important point about this case because when you're in a resource-constrained environment, you should choose your weapons carefully from cost point of view, and PET scan's very, very expensive. So it's not the first scan that we go to. We go with old-fashioned bone scan, CAT scan, and things like that before we reach, and we're hearing the other colleagues say the same thing elsewhere. And now we get to the endocrine therapy, and I think maybe maybe I can get Rasheen involved again. Rasheen, what do you think about her endocrine therapy as an alternative to systemic chemotherapy? Ben's already said no chemotherapy automatically, and I agree with that. So seeing as she's a highly ER/PR positive tumor, what would you do with her endocrine therapy at this point? And she's 31 and she's had a total abdominal hysterectomy by this time, or at least an oophorectomy. So she's postmenopausal now. So where would you go now?
I would probably switch her to an aromatase inhibitor because we all know in many settings the AI seems slightly better than tamoxifen, including in the metastatic setting, and she's now postmenopausal. So I think that the timelines are a little difficult because it doesn't seem as if she's been on treatment for too long and had her oophorectomy in May. But I think I would probably speak for an AI.
Jessica, a bit of feedback from Dr. Patterson. Dr. Patterson's microphone. Is Dr. Patterson there?
No.
No? Okay, we have feedback from somebody who left their microphone on, unfortunately. But anyway, if you can hear me, I think everybody's in agreement with Rasheen about her endocrine therapy. And I think we're ready. If everyone agrees, we'll go on to Dr. Campos presenting from Fortaleza in Brazil, the second case. Dr. Campos, can you turn your microphone on?
Yes. Good morning.
Good morning. Just 1 second, please. We're going to share the slides. Just wait. Give us 1 minute. We're nearly there. That's the end of Barretos, and there's Dr. Campos, a very beautiful picture of Dr. Campos.
Thank you.
Yes, thank you.
So thank you for the opportunity of telling our case from Fortaleza, Brazil. And it's about a 35-year-old premenopausal lady, no family history of breast cancer, previously healthy. And in January 2013, she had a palpable lump in the right breast. And she went to the consultation bringing a breast ultrasound, BH3 with a cystic lesion, 2.6 per 1.5 centimeters, 10 o'clock location in her right breast, 1.1 centimeters from the nipple. Next, please. So she presented with this palpable lesion, and she had another mammogram, BH1. And next, please. She had another ultrasound after the consultation with a guided biopsy that showed invasive breast cancer grade 3, triple negative, KI 67%, no lymphovascular invasion nor perineural invasion. So she had a PET-CT and that showed the breast lesion, the right breast lesion with 2.8 per 2.6 centimeters, and lefty right axillary node 1.3 per 1.2 centimeters with 5.5 SUV. Next. This is the PET scan. Next, please. Showing the lesion and the image of the axillary node. Next, please. So she had a breast MRI and showed only the breast lesion, 2.7 per 2.4 centimeter, and the UNO of the upper quadrants, and no axillary detected, no axillary node detected. So facing these two conflicted exams, she underwent a guided final needle biopsy of this right axillary node, ultrasound guided, and it was negative for malignant cells. She was offered genetic testing, but she declined at this time. Next, please. So she's a 35-year-old premenopausal woman with a stage 2, T2, and 0 triple negative invasive ductal carcinoma, KY 67%. So her treatment plan was neoadjuvant chemo that started from March to September 2013. She had this scheme of chemo, ACT, and after the neoadjuvant chemo, she had oncoplastic surgery with round block technique and sentinel lymph node biopsy. This was taken in October 2013. After that, she had radiation. She had 3D radiation, 50 gray to the breast, right breast, and 10 gray boost from November to January 2014. And after all the treatment done in November 2013, she finally accepted genetic testing, and it was BRCA2 positive. Next, please. So on the right, it's after surgery. So in the little picture, you see before surgery, and after surgery the bigger image. And the final pathology was a complete pathological response and negative margins. Next, please. This is the view of the treatment, the radiation 3D treatment, and the isodose. Next, please. So we bring for this discussion first the role of platinum in neoadjuvant chemo for young patients. Secondly, how to deal with this discordant PET-CT scans findings, especially in the axilla? Would it be different, the surgical approach? And now in 2015, after this genetic testing positive, what would be the management or follow-up? Thank you.
Thank you very much. You're asking very excellent questions that we struggle with in our tumor board locally. So again, if I can pick on maybe Ben, who would like to kick off. Ben, would you just talk about your approach of neoadjuvant chemotherapy in a young woman with triple negative breast cancer with or without BRCA testing positive?
So, you know, as many probably are familiar with, there's some data emerging that platinum agents in the neoadjuvant setting for triple negative disease may afford better outcomes, or at least higher pathologic complete response rates. We have not routinely recommended, or at least I haven't, platinum for all young women who are triple negative in the absence of a positive BRCA or other types of germline mutations that are in the BRCA pathway. And that said, I think that there is a role, and an emerging role again, for doing or adding some sort of platinum agent to the neoadjuvant chemotherapy regimen for these women. So in this particular case, had she received the diagnosis of having a BRCA2 mutation, I think I would have considered adding carboplatin to her taxane, as some studies have suggested, or if she had had a really striking family history, because I know in some parts of the world BRCA testing isn't readily available. She did not, so it's a little bit hard to say. But again, this is an ever-changing paradigm, so we don't really know. She achieved pathologic complete response, so that makes one feel better that she did quite fine with the regimen that she had. At the same time, we also know that pathologic complete response is not a perfect surrogate, and in some series, maybe up to 20% of patients will still relapse despite achieving PCR. So I think I would have been okay with this, but had I known the BRCA2 information ahead of time, I would have considered adding carboplatin.
I think I'm going to say, and I hope I'm still right, that at MGH we also don't routinely give platinum automatically to all triple negative young patients, but we do exactly the way Ben says, for patients who are BRCA positive or for patients in the absence of BRCA testing with a very strong family history of breast cancer, so surrogate for BRCA positive. But otherwise we don't give it. Actually, I'd like to ask Charlotte Gale. Charlotte, would you like to comment on the surgical approach because of discordant PET findings in the axilla? The second question here. Would you like to say something? It's just let's have Charlotte Gale.
Is it working?
Yes.
Yeah, we can hear you. Thanks.
I think you would start based on your physical exam. If you have any suspicious nodes that you can feel, you should try to biopsy them. And we always put a clip in anything, you know, that we biopsy so that we know which lymph nodes were positive at the time for clinical staging. And then after we give the chemo, we restage them as a Y, C, you know, N, whatever. And if it is lymph node negative, then we'll do an extended sentinel lymph node biopsy, which is the radioactive tracer, the blue dye, as well as the clip itself, and we'll get a specimen radiograph to verify the clip. So I think that, you know, in the absence of the BRCA mutation, breast conservation with sentinel node is very reasonable, and how we would proceed, how I would proceed.
Great. Seema, do you want to say something?
Right. So I just want to add that ultrasound is actually a very useful imaging technique in this setting. It will show suspicious lymph nodes and facilitates a core needle biopsy and the placement of the clip, as Charla mentioned. So the PET scan, of course, has limited resolution. But in this case, it showed the node and the MRI didn't. The MRI is not nearly as sensitive for diseased lymph nodes, so it's not a very reliable test for diseased lymph nodes. I think with a positive PET scan, I would certainly have looked for a lymph node with ultrasound and tried to biopsy it that way. And as Alphonse will probably elaborate on, that makes a difference to the radiation treatment planning in particular. The question I have is that the sequence of events seems to be that the patient consented to her BRCA test following surgery but prior to radiation. And so I wonder, was prophylactic mastectomy discussed at that point? Because the reconstruction, if she decides for it in the future, will certainly not be optimal given the use of radiotherapy on the treated side.
Thank you, Sina. That's a good bridge to Alphonse making some comments about this.
Right. So I want to go back to the issue of this lymph node based on the story presented here. So we have a PET scan positive, an MRI negative, and we have a triple negative tumor in a young woman. So it's likely that this lymph node was positive. And I would lean toward assuming it was a positive lymph node which turned into a negative lymph node after neoadjuvant chemotherapy. And this happened in 20 to 40% of the time. This will make a big difference from a radiation perspective. And although I would say the standard of treatment at this point in this scenario, assuming it was positive which turned negative, is to give regional radiation. And this is a question raised in a large NSABP B51 R2G trial, which include women who had documented positive lymph nodes with FNA or with a biopsy. And it's nice also to put a clip there, like was mentioned. And after neoadjuvant chemotherapy, it is documented that these lymph nodes became negative. So the patient responded very well to neoadjuvant chemotherapy. These women will be randomized between breast radiation only, as this patient received, versus breast radiation and regional lymph node radiation, including the supraclap and the IMC. So the question is actually raised in the radiation oncology field. But until we have an answer to that, I usually lean toward giving the regional lymph nodes, especially based on how aggressive this tumor is.
That's great. We'll circulate details of the study of B51, NSABP B51, after the tumor board. So any other insights into this case before we move on? Anybody want to speak?
I guess the BRCA issue here
Yeah.
should be discussed, whether the patient will have now bilateral mastectomy.
It's a good point, yeah. So what do you think about, does anybody have a, let's go back to Charlotte again. What do you think about prophylactic mastectomy in light of the fact that she's now BRCA2 positive after her neoadjuvant mastectomy?
Well, I think that we know that her risk is going to be high if she's a BRCA carrier. You know, the penetrance is different in every family, but we know that her risk is high with that mutation. So she should be counseled about risk-reducing surgery, not only for the breast, but as well as for her ovaries and whatever her fertility status is. We need to, you know, they need to talk to her about that. But, you know, the timing, I mean, she can get, the bilateral mastectomy is not going to change the cure for this breast cancer. It's just going to change the chance of her future genetic BRCA-related cancers in the future. So,
Actually, that's a point, Charlotte. Thank you. That's a point I'd like to raise. You know, the role of preventative breast cancer surgery or medical therapy is diluted by the prognosis of the patient with first primary cancer. So if a patient after neoadjuvant therapy of a unilateral breast cancer has, say, like 10 positive nodes or 5 positive nodes, post-neoadjuvant therapy, it calls into question the mathematical modeling, the cost effectiveness of performing a contralateral mastectomy. Even though she's at tremendous risk, what is the balance, you know, what on balance is the likelihood that she'll die from a second cancer as opposed to her first cancer? So I don't know whether you ever consider, Stima, do you ever think about that, or do you just give her the benefit of the doubt and do prophylaxis anyway?
No, I think you make a very good point, and that's something that should be considered every time. The burden of risk posed by the index cancer is a very important part of this sort of balancing. In this particular woman, though, she's had a complete pathologic response with neoadjuvant chemotherapies, and she had a smallish tumor to begin with, and so on. So I think with her, the risk-benefit balance favors prophylactic mastectomy somewhat, but there are certainly women who decline it, and in that case, she needs to be followed with bilateral MRI. That would be another important component of her surveillance going forward. Her oophorectomy, of course, will decrease her risk of developing new primary cancers, particularly since she's BRCA2, since the benefit of prophylactic oophorectomy in reducing breast cancer risk seems to be somewhat larger for that group. So prophylactic oophorectomy is something that should be pursued strongly with her, particularly as she gets close to 40. Prophylactic mastectomy is certainly something that should be discussed. And in someone who's identified to be BRCA2 positive, or one for that matter, prior to radiation, that's a useful window because the radiation does alter the reconstruction results.
I think the point I'm raising, thank you, Seema. I think the point I'm raising is the issue of mathematical modeling around competing risks is a complicated business. I've had the benefit of sitting in with statisticians discussing this. I don't think we clinical oncologists have an accurate way of counseling our patients on competing risk. If a patient had non-small cell lung cancer 2 years ago, does she need, how much preventative for another cancer does she need? And what's her real cumulative prognosis between a new cancer plus the old cancer? So it's like bilateral breast cancer. There's a competing risk, and it depends on timing and stage and all kinds of factors. I do think there's an absence in clinical practice of an easy to apply, if such a thing exists, mathematical model of competing risks. We all see papers on this about competing risks of if you've had a heart attack in the last 5 years, is it worth getting chemo for your breast cancer, and so on and so forth. I think competing risks is a complicated business about patients' age, different diseases competing for the patient's health, and I think that this is I just raised it here because it's a very glaring example of competing risks. But thank you very much, Seema. I think we should go on to Yuli's case if we can, in the interest of time. So Yuli, we're getting ready for you to present your case, please. If you turn your microphone on from Mexico City.
Good morning.
Good morning. Can you speak up a little bit or turn your microphone up a little bit? Try again for the good morning.
Good morning.
That's better. Thank you. Go ahead, please, from Mexico City.
Right here.
Our case is about a 55 years old premenopausal woman with family history of father and a 41 years old sister with breast cancer. Previously healthy. About June of this year, she felt a self-detected left breast lump, and a mammogram and an ultrasound, and we got the results with BRAF5 with pleomorphics and microcalcifications, with a biopsy with ductal carcinoma in situ with solid and papillary type grade 3 with microcalcifications and comedonecrosis. No invasive component is detected. About August of this year, and in consideration of probably BRCA mutation likely in light of family history, she had a bilateral prophylactic mastectomy and left sentinel lymph node biopsy and posterior immediately reconstruction. With a pathology in left breast with a ductal carcinoma in situ, comedotype, grade 2, with microinvasion and a positive medial margin. Estrogen receptors 90%, progesterone 40%, HER2 negative, and Ki 67, 25%. The lymph node had an isolated groups of neoplastic cells, and the right breast has no malignancy. In conclusion, it's about a 55 years old premenopausal woman with likely BRCA mutation and a ductal carcinoma in situ with positive margin after bilateral prophylactic mastectomy. Our plan is observation versus radiotherapy, and the questions are: what is the risk of local and distant recurrences in this case? Would you offer adjuvant radiotherapy? And if yes, what is the benefit and what is the risk of second malignancy in this patient with probably BRCA mutation?
So thank you very much. This is a great opportunity to welcome Dr. Carol Marquez from Stanford University. And Carol, you want to have some insights, give us some insights into the use of radiation therapy in this patient.
So this woman has undergone a mastectomy for DCIS and has a positive margin for DCIS. And there is now at least 3 series showing that the addition of post-mastectomy radiation therapy in that setting is not beneficial because there's a low risk of local regional recurrence, even though there's a positive margin. So unless there's some other data out there, and something else out there, I would not recommend post-mastectomy radiation therapy for this patient.
And if you did give radiation to this patient, are you concerned about the risk of second malignancies in a BRCA carrier?
Not in the post-mastectomy setting any more so than I would be, because there's very little breast tissue left, so I don't think that there's evidence to support that the radiation has a higher likelihood of inducing a second malignancy in the other tissues that are remaining.
Alphonse, do you want to add something? Thank you, Carol.
Yeah, it's not traditional to give post-mastectomy radiation for DCIS, but it is a very difficult question, and it depends on many things. What was the quality of surgery? Did the surgeon leave like significant breast tissue behind? Did the patient have this overwhelming, something like a snowstorm of calcification with DCIS all over the breast? What was in this positive medial margin? Was it one focus of DCIS close to a margin, or it's along a broad front? There's a lot of questions here that need to be answered because this woman is a young woman, and her survival is very long, and then like having local failure after mastectomy for DCIS is not unheard of. We have seen a few of those. So a lot of factors here really come into the decision whether you give post-mastectomy radiation or not. The other thing about the radiation-induced cancer, I think what was meant probably radiation-induced sarcoma. Yes, the patient could be at risk. The risk is 0.2% at 10 years. And might increase a little bit at 20 years. The risk is low, but it's there. So this is not...
Is that in a BRCA carrier?
No, this data comes before the
for everybody, yeah, right.
So I don't know what is the risk of radiation-induced sarcoma in BRCA carrier. So that's really unknown. It could be higher than that.
Right.
So it is a difficult question. It's not 100% no, we should not give post-mastectomy radiation. It's not 100% we should give post-mastectomy radiation. And we struggle with this question all the time. I think there is a study from Kaiser Permanente showing that positive margins give a higher risk of local failure. In fact, for every comer, the risk of local failure is actually 2%. I mean, it's 90% control rate for after mastectomy for DCIS. But when you have those factors, it can go up to 7%. Is 7% good enough to give post-mastectomy radiation? That I'm not sure about that. So this will need a discussion. It's not an easy answer.
Maybe we could get some surgical perspective. Seema, would you like to comment?
So I actually lean towards Alphonse's arguments here because although the value of radiotherapy is not definitively proven, the risk certainly for this group of features is higher, particularly her young age. There's a recent series from France of 200 plus women DCIS treated with mastectomy, and the major predictor for chest wall recurrence following mastectomy was young age, actually not margin. So this is a woman who has who's young, who has an involved margin, who has some microinvasive disease, who also has some cells in her node, which, you know, we don't know how many cells exactly, whether these are isolated tumor cells or count as microinvasive disease. So more pathologic information would certainly be very helpful. I mean, what we would normally look at is, as Alphonse mentioned, the face of the positive margin. Is it just a millimeter or so? Is it in one block? Is it in several blocks? And so on. But you know, on the spectrum of DCIS, this is a worrying combination: the young age, the positive margin, the microinvasive disease, and the possibility of nodal invasion. So I think it certainly deserves discussion of radiotherapy. And if the patient is so inclined, I mean, agreeing that this is a relatively data-free zone, the risk may be high enough to actually justify radiotherapy.
Thank you, Seema. Charlotte Gale, would you have the courage to disagree with Seema and Alphonse?
That's easy. No, I wouldn't.
Okay.
But what I would say is that if you look at this and it was a strictly an in situ cancer, and you remove and you're positive at the fibroglandular border, it's in situ, and additional local therapy would be treating breast tissue. But this isn't clearly in situ because it's in a lymph node. So there is microinvasive disease, so it's a little bit there is some benefit to thinking about radiation. And I would send her over to talk about radiation. But my question would be about reconstruction. What did she? I missed that part. If she had anything for reconstruction, was it autologous or implant or tissue expander or nothing?
Can you answer from Mexico City? Has she had reconstruction, and if so, what?
Yes, she had reconstruction.
Well, how did she have?
With tissue expansers. With tissue expansers. Yeah.
Okay, thank you.
And that's one of the things that some of the radiation oncologists are getting into about, switching them out to permanent or keeping them overinflated, or, there's a bunch of different regimens. So that would go into what you would want to do from there, but that's a radiation oncology question.
Yeah, I mean, just to comment on the impact of radiation on reconstructed breast, well, it has a negative impact, no doubt about it. It increased the risk of complication, it increased the risk of encapsulation, of tenderness, of cellulitis, and sometimes they have to remove the expander or the implant just because of radiation. But this is usually maybe around 20%. Sometimes we request the exchange before radiation, and that's the Memorial Sloan Kettering technique, which we usually actually do it here also, or sometimes we do the exchange after radiation. Plastic surgeons don't like to operate in an irradiated field. It makes things more complicated, no doubt about it. But again, looking at the benefit, every time you give radiation, there is a reduced risk of local failure by 2/3 to 75%. So this is universal in almost every paper. The question is, what is the original risk? If you start with a risk of 7%, it will go down to 3%. Does this outweigh the potential side effects from radiation? If you start with a risk of 20%, it goes down to 5%. Here the benefit is big. And again, this is a case where we really struggle, and there is no right or wrong. There is no a clear answer to it, but all those things will be involved in the discussion, I guess.
Thank you. Seema, you're going to send us the reference from the French study that you cited, please, to Jessica. She'll communicate. And can we get Carol? Did you comment on this case?
Yes, I did.
Oh, you're very
yeah, I commented. I was the dissenting voice saying that there are several studies saying there's no need for radiation.
Okay. No, I just thought you had a follow-up question, but thank you very much. So, does anybody else have any questions? We had 3 very young patients presented today, all very worrisome, and so thank you very much. Unless has anybody got a comment?
Here's a comment.
Yeah?
Here.
What is it? Can you read it? We just have a comment from a viewer, if you don't mind. If you just, somebody's asked a question that I think Charlotte Gale raised. As this patient has microinvasive disease in a lymph node, is it not stage 1 invasive ductal cancer and not DCIS already by definition? Alphonse, that is a good question.
I don't know. I mean, it's good. If there is no evidence of invasion in her breast, it will be TIS, and then it will go to probably NI plus. So it's still
DCIS.
Yeah, NI plus is an N0 by definition. So based on the TNM, she is still DCIS, but we know that it's more than that.
So it's a good question.
Yeah.
It's right on the border. A very excellent question from one of the viewers. Thank you. It was Alphonse is saying that she's sort of on the border of definition between. She's technically still DCIS, but we all deep in our heart know that she has microinvasive and invasive ductal cancer. Any other comments? Was there anyone else a comment, Jessica? The question?
There were some comments going back and forth between viewers and the presenters.
Okay. We're just taking a minute to look at comments from people who are not on camera, but who are watching from around the world. Was there a reason for T? This was the first case from Brittany Lee, who's our colleague at the Dana-Farber Hospital here in Boston. Hi, Brittany. I'm not sure why Brittany isn't on camera, but anyway, was there any reason for T being given before AC in the first case? So can we go back? Can we just step back for a minute? We have another few minutes to Dr. Marina Costa and ask that question of you. Was there a reason you gave T before AC as neoadjuvant chemotherapy in case number 1? That was just to remind everybody, that was a 31-year-old woman who had a highly PR-positive tumor and received neoadjuvant chemotherapy with T times 7 and dose-dense AC times 4 afterwards. And that's the question from Brittany Lee. And I would take any question from Brittany very seriously and be careful how you answer it.
Hi, and here we follow the MD Anderson protocol, and for patients HER2 negative, we can change and beginning with paclitaxel, not for AC. But for patients HER2 positive, we usually begin with AC plus paclitaxel.
Can I ask about our panelists like Ben Park? Ben, can you say what you think about this?
Yeah, we follow a more traditional AC up front, followed by T. You know, again, there are some studies that support you can do the T component up front, but I think, you know, in the setting of what we are used to, you know, the taxanes, as you know, was really added to AC afterwards, and there are some studies which have looked at difference in sequence. It's not clear to me whether there's an advantage of doing one over the other, but here at Hopkins, we generally like to give the AC up front, followed by the T.
So I think everybody, Rasheen, what do you think about it?
I agree with what's been said. I just wanted to add that, you know, if we do clinical studies sometimes, we start with Taxol, you know, adding a new agent to Taxol. So I don't think it's incorrect to do it. I just think that most of us are more familiar with doing AC followed by T.
So it's important for everybody to hear that even here in the United States, there's some, there are two alternatives sort of equally weighed at the moment, and there's no definitive answer between Taxol up front. There's good reason to perhaps give it based on emerging data and clinical trials, but the traditional view that Ben has expressed is to start with the AC times 4. So I hope we've answered everybody's questions. We've looked through the questions, and that seems to be the key ones. Thank you very much to the panel.
Can I just make a small
please,
comment?
go ahead,
So I just want to acknowledge Marina's response about the imaging for this case. Apparently she did have a mammogram and ultrasound, and she had some peau d'orange. So so that puts it in a different category. If the peau d'orange really meets the clinical criteria for inflammatory breast cancer, I think no one would argue with the use of neoadjuvant chemotherapy in that setting.
Thank you, Steve. So you were questioning, because I remember you raised this when we discussed the case. Is it
right.
stage
And
3?
Marina responded that she did have mammogram and ultrasound, yeah.
Yeah, okay. Thank you very much for that clarification. Thank you, Marina. Thank you, Seema. Okay, I think we're done. We're just on time, and we'll archive this discussion, as I said, and we'll archive the case histories, and we'll categorize them into subjects that you can look at. We're going to be unveiling our new archive systems soon. for people to look at, for your students and residents and other people, your colleagues who couldn't make it. But in the meantime, I want to say thank you very much to the presenters for excellent cases and to our panelists for a lively discussion. Thank you very much, everybody. Thank you.
Thank you.